If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. Today we will go through the primary care management of polycystic ovarian syndrome, focusing on what is relevant in primary care only. For this advice, I have looked at the published advice on the NHS website, North East London Integrated Care Board, and Health Improvement Scotland. The links to them are in the episode description. If you haven't already, I recommend that you watch the previous episode where I cover the initial assessment and diagnosis. Right, let's jump into it. And let's start by reminding ourselves of the referral recommendations. We should consider endocrinology referral if there are severe symptoms, such as signs of virilization or rapidly progressing hirsutism. Also, when testosterone is significantly elevated, defined as greater than 5 nanomoles per liter or more than twice the upper limit of normal. Or abnormal levels of dihydroepiandrosterone, androstenedione, or 17-hydroxyprogesterone, which could indicate the possibility of alternative diagnoses, such as congenital adrenal hyperplasia, Cushing's syndrome, or androgen-secreting tumors. Otherwise, the management of polycystic ovarian syndrome is symptom-driven, so we should identify the patient's main concern, whether it's menstrual irregularity, hirsutism, fertility, or metabolic risk. Also, we should not neglect psychological well-being, given that many women with polycystic ovarian syndrome are at an increased risk of anxiety, depression, and body image issues. We should therefore screen for symptoms of anxiety and depression, as well as other mental health conditions, and offer appropriate management if indicated. For all patients, lifestyle modification is the first line of treatment, especially in those who are overweight. A weight reduction of even 5% can restore ovulation, reduce androgen levels, and improve insulin sensitivity. Women should be counseled that although polycystic ovarian syndrome is associated with weight gain, it does not inherently make weight loss more difficult. Referral to local weight management services may be appropriate and could be advised. Cardiovascular disease risk should be assessed by assessing individual risk factors, and we should counsel patients on possible long-term complications, including type 2 diabetes, hypertension, hyperlipidemia, cardiovascular disease, obstructive sleep apnea, and endometrial cancer. Screening for type 2 diabetes is recommended, especially if they have a BMI over 25 or additional risk factors such as age over 40, gestational diabetes, or a family history of diabetes. Although HbA1c is usually preferred for the diagnosis of diabetes for practical reasons, the North East London Primary Care Guideline recommend testing with oral glucose tolerance test instead. Let's stop here for a moment and ask ourselves, why would an oral glucose tolerance test be preferred in polycystic ovarian syndrome? There are two main reasons. Firstly, because HbA1c can miss impaired glucose tolerance, given that postprandial glucose spikes may occur early in the disease process, even before fasting glucose or HbA1c becomes abnormal. Also, HbA1c can miss early glucose dysregulation, especially in younger women and those with mild or intermittent abnormal glycemia. So this is why an oral glucose tolerance test may be preferred over HbA1c in these situations. But let's go back to the general management. And as we said earlier, the treatment should be symptom-driven. So let's now look at the treatment in specific clinical scenarios. From a practical perspective, we should check whether the patient is pregnant or trying to get pregnant. If they are, we should stop any hormonal treatment, offer preconception counseling, including high-dose folic acid, 5 mg if obese, refer them to fertility or obstetric services depending on the situation, and if pregnant, we should also organize an oral glucose tolerance test. Fertility treatment in secondary care may include ovulation induction with drugs such as clomiphene or letrozole. If this fails, gonadotropin or laparoscopic ovarian drilling may be considered. But if the patient is not pregnant and not planning to get pregnant, we will check which symptom they are most concerned about and treat each patient holistically according to their concerns. This could be acne, hirsutism, or oligo or amenorrhea. Let's have a look at the management of acne first. For this, we can offer the combined hormonal contraceptive if appropriate. Any other acne treatment as per dermatology guidelines, or we could prescribe spironolactone, checking baseline use and ease and considering ongoing monitoring if clinically indicated. For example, if they are aged 45 or over or have other relevant comorbidities. Although this is an unlicensed use, the Northeast Primary Care Guidelines advocate their use in general practice. But spironolactone is a potassium-sparing diuretic. Why does it work in acne? There are two ways: by blocking androgen receptors and by reducing androgen production in the ovaries and adrenal glands. Since androgens stimulate oil production in the sebaceous glands, blocking their action leads to less sebum and reduces the clogged pores and the inflammation that causes acne. Let's now look at the treatment options for hirsutism. They are hair removal methods, for example shaving, waxing and laser. The combined hormonal contraceptive, considering Dianet, which is a combination of cyproterone acetate and ethinyl estradiol. Metformin, which should be considered over inositol for hirsutism and central adiposity. And finally, the BNF also states that for hirsutism, topically applied eflornithine or Vanica is of some benefit in reducing facial hair growth and should be used for 6 months prior to referral for laser treatment. What do we need to know about eflornithine or Vanica? Eflornithine inhibits specific hair follicle enzymes, slowing down the rate of hair growth, making facial hair appear finer, lighter, and less noticeable over time. Key points that we need to know about this is that it does not remove existing hair, but reduces regrowth speed. Effects may take 8 weeks or more to become noticeable. It's often used alongside other hair removal methods like plucking or laser. And once treatment is stopped, hair growth usually returns to baseline. Eflornithine is particularly useful for women with mild to moderate facial hirsutism who prefer a non-hormonal, non-systemic option. But we have also just said that metformin should be considered over inositol for hirsutism and central adiposity. But why? And what are inositols? And how do we prescribe them? Well, in the UK, inositol is not available as a licensed prescription medicine in the BNF, and it is considered a dietary supplement. Some international polycystic ovarian syndrome management guidelines note that inositol could be considered for metabolic improvements like insulin resistance. But evidence for reproductive benefits, such as ovulation or hirsutism, is still limited, and no specific dose or form is recommended. Some private or fertility specialists may support its use, giving its good safety profile and occasional anecdotal success, but it cannot be formally prescribed. So if it cannot be prescribed, how are people accessing it in the UK? At the moment, it can be obtained from supplements retailers or specialty health stores. The Northeast Primary Care Guideline does recommend inositols for some aspects of polycystic ovarian syndrome management, but obviously it is a grey area where your individual clinical judgment will be the deciding factor. How does inositol actually work? Inositols are naturally occurring sugar alcohols that act as second messengers for insulin at intracellular level, improving insulin sensitivity and decreasing androgens. Why is metformin better than inositol for hirsutism? There are various reasons. Firstly, there's evidence that metformin reduces central adiposity and insulin resistance more consistently than inositol. Then metformin has a greater effect on hirsutism. We need to remember that hirsutism is largely driven by hyperandrogenism, and that metformin indirectly lowers androgens by improving insulin sensitivity, which in turn reduces ovarian androgen production. Inositols may reduce androgens too, but the effect is milder and less predictable. When might inositols still be considered? We can recommend them if a patient cannot tolerate metformin, in mild polycystic ovarian syndrome symptoms without central obesity or significant insulin resistance, if there is a patient preference for over-the-counter non-pharmacological treatments, or as an adjunct to other therapies. If the main concern is oligomenorrhea or amenorrhea, we need to remember that oligo or amenorrhea is a risk factor for endometrial hyperplasia and carcinoma, and we should aim for a minimum of 4 periods per year to protect the endometrium. So, in this situation, we should organize a transvaginal ultrasound to assess endometrial thickness if there has been prolonged amenorrhea or abnormal vaginal bleeding. An endometrial thickness of less than 7 millimeters makes hyperplasia unlikely. Referral for biopsy and possible hysteroscopy should be considered if the endometrial thickness is raised. The treatment options for oligo or amenorrhea are a cyclical progestogen, for example medroxyprogesterone 10 milligrams daily for 2 weeks every 2 to 3 months, the combined hormonal contraceptive, the levonorgestrel intrauterine system, metformin, which may be most beneficial in high metabolic risk groups. We need to be aware that metformin is not licensed for treating polycystic ovarian syndrome, but it can be used off-label if clinically appropriate. However, the BNF states that treatment with insulin-sensitizing drugs, such as metformin, should not be prescribed routinely as first-line therapy, and it should only be initiated by a specialist. There is evidence that metformin improves short-term insulin sensitivity and also reduces androgen concentrations. But there is limited supporting evidence on the long-term benefits in polycystic ovarian syndrome. So this is why it should only be prescribed in the context of a specialist endocrine clinic. And finally, other options for oligo or amenorrhea include a progesterone-only pill such as drospirenone for their anti-androgenic effect, and inositol, although the evidence is limited. Before ending, let's look at combined hormonal contraception in a little bit more detail. One of the known benefits of combined hormonal contraception is that it increases sex hormonal binding globulin. So, combined oral contraceptives are commonly used in polycystic ovarian syndrome for the treatment of acne, hirsutism, and menstrual irregularity. But again, this is an unlicensed indication. But why does combined hormonal contraception increase sex hormonal binding globulin? The main reason is the estrogen component of the contraceptive, normally ethinylestradiol, which has a hepatic effect by increasing synthesis of several proteins, including sex hormone binding globulin. Then the higher circulating sex hormone binding globulin levels bind to free testosterone, reducing the free androgen index. This leads to reduced clinical signs of hyperandrogenism like acne, hirsutism, or alopecia. So that is it, a review of the management of polycystic ovarian syndrome. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.